So let me thank the organization for inviting me. I will briefly discuss what are the current HIV-related treatment options in primary care as internal medicine physicians. So we'll look at initial evaluation, some new data on opportunistic infections, antiretroviral therapy, of course, and finally PrEP and PEP. So one of the things that has happened over the years is in the diagnostic algorithm of HIV, it's very important to remember that currently there is no role for Western blot. It has not been there for the last decade or so actually, but still Western blot is being done. The screening algorithm starts with the fourth generation ELISA. If it is positive, then you do a rapid ELISA to differentiate between HIV-1 and HIV-2 infection. If the rapid ELISA is negative or indeterminate, you can do an RNA testing to rule out acute HIV infection. But if the upfront fourth generation ELISA is negative, then there is really no need to further pursue the diagnostic algorithm. So the message I wanted to give here is no role for Western blot. You need to start with a fourth generation ELISA followed by a rapid HIV-1-2 differentiation assay. First, of course, when a patient walks into the clinic, if he's visibly sick or clinically having an opportunistic infections that needs to be ruled out, CD4 counts need to be performed at baseline. And regardless of the CD4 count, you need to do a Hep B, Hep C screening, syphilis screening, and creatinine. For all women, remember this is very important to ask them to get a cervical pap smear or an HPV DNA assessment. And this has to be done at least every 3 months, 3 years. And this is because the risk of HPV related cancer is higher amongst women living with HIV as compared to HIV negative women. At each visit in your clinic, you should always screen for what is called as a W4SS screening, which is asking the patient for fever, weight loss, cough, and night sweats. If any of them are positive, then we need to screen for tuberculosis. If all of them are negative, then it has a good negative predictive value to rule out active tuberculosis. And in patients with CD4 200 or less than 100, you need to do a serum cryptococcal antigen screening routinely. If it is positive, then you need to rule out cryptococcal meningitis by doing a CSF analysis and then treat it accordingly. So very important in your routine practice to screen for cryptococcal antigen when the CD4 is less than 100. Now let us talk about two opportunistic infection. This was what I mentioned was the W4SS simple tool for TB screening. As you see here, even on antiretroviral treatment, every time when a patient comes, if you ask for these 4 symptoms, it has a good sensitivity around 53% and specificity of around 70%. So please ask for these symptoms and rule in or rule out tuberculosis based on this. As in non-HIV TB, in HIV also, the challenge is in diagnosing TB, but in terms of expert ultra, it has been demonstrated to be quite useful as a screening tool upfront rather than smear status, because smear status sensitivity is lower in the HIV context. While expert ultra has a better sensitivity than the old expert MTB-RIF, it has lower specificity, as you see here, as compared to expert MTB-RIF. So the WHO currently recommends amongst all adults and adolescents living with HIV to have rapid molecular tests be used for screening for TB disease if a patient is positive on any one of the W4SS score. The other thing which we often do not really scale up in our private practice predominantly is using INH prophylaxis when we are initiating antiretroviral therapy, regardless of the CD4 count, to prevent tuberculosis. And this data recently shows that the benefit can go up to 5 years and has a non-statistically significant trend in improving mortality. So it's important to initiate 6 INH, which has shown to have a durable benefit along with antiretroviral treatment to reduce the residual TB burden amongst patients on ART. Since INH is for 6 months has a problem in terms of adherence. Now there are short course regimen, 1 month of INH rifampicin daily, or 3 months of high dose rifampicin and INH weekly. Both of these regimens have been shown to be effective in the context of HIV infection. So we need to scale up use of these when we initiate ART in patients with HIV to prevent TB. So this is also now being recommended by WHO. The latest consolidated guidelines recommend these regimens. One important advance has happened in the treatment of cryptococcal meningitis in the HIV infected scenario, where a single high-dose liposomal amphotericin B was shown to be non-inferior to the conventional amphotericin B with flucytosine regimen. So this trial, because of this trial, the current WHO recommendation for treatment of cryptococcal meningitis has been updated to a single high dose 10 milligram per kilogram of liposomal amphotericin B, plus in addition 14 days of combination flucytosine and fluconazole in these doses as an induction therapy. So this is practice changing, and this reduces the need for the duration of hospitalization, as well as may be able to avoid offset costs associated with long-term hospitalization with conventional amphotericin B and flucytosine. Finally, as far as OI prophylaxis is concerned, we know that we can discontinue primary or secondary OI prophylaxis in individuals who are successfully treated on antiretroviral therapy when they have a CD4 count of more than 200 or sometimes even 100, particularly if the viral load is less than 50 copies sustained over a period of 6 months. So remember to remove that, remember to initiate TMP-SMX when the CD4 is less than 200, and remember to discontinue TMP-SMX once the CD4 is more than 200 and an undetectable viral load persists for 6 months. Now let us come down to what is the current status as far as use of antiretroviral therapy amongst HIV infected individuals is concerned. And here we have this concept of rapid ART initiation, which is defined as ART initiation within 7 days of diagnosis of HIV infection. So very rapid ART initiation has to be done so that these patients can continue to be on ART, and there is no loss to follow-up, which happens if there is a gap given between diagnosis and treatment initiation. In a meta-analysis, it has been shown to reduce the incidence of TB as well as severe bacterial infections, though it did not show impact on mortality or the proportion of individuals with undetectable viral load. So this is something which is advocated now for all people living with HIV, irrespective of whatever opportunistic infections they have, predominantly around 2 weeks. You need to start in the presence of active OIs, except tubercular meningitis and cryptococcal meningitis, where you may need to delay the initiation of ART up to 4 to 5 weeks of starting treatment for these infections. For treatment of naive patients now, this is what is currently recommended. Normally, we have been using these 3 drug regimens. Currently, it is being moved towards using integrase inhibitors, and we know even the free government program is currently offering dolutegravir-based regimen. The backbones have also changed from our old zidovudin and stabudin to TAF, TDF, or TAF FTC or TDF 3TC, and abacavir 3TC if the HLA-B5071 is negative. So integrase inhibitors based regimens with a backbone of 2 nucleosides, tenofovir based, are preferred, and most of our patients would be going on that regimen. Alternatively, for some reason, if it's not possible, if there is intolerance to these, you can use an efavirenz low dose 400 milligrams as an alternative regimen. There is now enough data to suggest that we can now also look at 2 drug regimen like a dolutegravir with lamivudine combination. So 2 drug regimens have been found to be non-inferior to 3 drug in naive population as well as in simplification. So in our clinical practice, we can use 2 drug regimen like DTG3TC in naive patients if the baseline viral load is less than 100,000 and the Hep B is negative. In the simplification scenario, we can use it in a patient who is stable on a ART, has viral load less than 50 copies at least for 6 to 12 months, and has no historical DTG3TC resistance and is HBsAg negative. So this is where we can use, and we have currently been simplifying a lot of our patients onto a 2-drug regimen from a 3-drug regimen. For HIV TB, we still are looking at efavirenz 600 milligram and DTG BID. No other core antiviral drug can be used with rifampicin. So this is the option for HIV TB with rifampicin, 600 milligrams of efavirenz. When we use dolutegravir, we need to double the dose of dolutegravir, and we can't use TAF in the context of rifampicin. We need to use TDF in that context. Once you start somebody on antiretroviral treatment, you need to monitor them for success. We need to look at viral load, and we need to achieve an undetectable viral load by 6 months of initiation of ART. That, of course, you would also see an improvement in the CD4 counts that has to be monitored. So this is the current monitoring schedule recommended. You do a viral load at 6 months, and the goal is less than 50 to 200 copies, and then you can follow up the viral load every 6 months or once a year at least. For CD4 counts, you initially start with 6 months, and once it's more than 350 or even 500, you can stop monitoring CD4. So we have stopped monitoring with our CD4, our patients with CD4 count for quite some time now, and monitoring only with viral loads once they have achieved a decent CD4 count. Most important is every time you assess adherence in your clinic and reinforce the importance of adherence. Though now with contemporary modern regimens, the cutoff level for adherence is around 80%, vis-a-vis previous regimens where we used to ask for 90 to 95% adherence. Of course, some patients with failure antiviral treatment, and this is an important trial which shows that you can move to a second-line regimen with an integrase inhibitor if you fail an NNRTI-based efavirenz-based, for example, regimen, and keep the backbones the same. So this is what is followed now. If you are failing an efavirenz-based regimen, you can go to a DTG-based regimen. Backbones may not be changed. Failing INSTI-based regimen, you need to move to a darunavir-ritonavir-based regimen in your second line. And importantly, there is no need for resistance testing because these two drugs are quite powerful in terms of not only potency, but a high genetic barrier to resistance. With this newer contemporary ART, there are some newer toxicities. So this is weight gain, which is commonly seen with integrase inhibitors as compared to the previous drugs, and with the TAF as compared to the other nucleosides. So in our clinical practice, we need to monitor weight and calculate BMIs of our patients at every follow-up visit that they come to us. Then we need to screen for metabolic parameters, particularly baseline and subsequently annually blood sugar levels and lipid profiles. And based on that, we need to calculate CV risk assessment and design interventions as we would do them in our normal population. So it's very important to consider statins, manage with antihypertensions, control the sugars of this patient because these patients are aging, in addition to having some toxicity associated with metabolic complications of these ARVs. With the TDF, you have nephrotoxicity happening higher, though with TAF it is little less, and so is true with the bone marrow, bone mineral density, which can decline with the TDF. So for renal toxicity, we monitor creatinine and urine, especially if you have using TDF with comorbidities or with a boosted PI. And with BMD studies, we usually restrict it to our patients who report to us with fractures. And if they are osteoporotic, we treat them with the bisphosphonates. The other important complication is TB iris, and this is something which is important, that any patient who comes to you with TB and HIV, you initially start TB treatment, and then you initiate ART about 2 weeks later. If the CD4 count is less than 100, they have a high risk of developing TB iris. So to prevent that, you can give prophylactic steroids and continue that for around 4 weeks. and you can see a 30% reduction in the risk of development of iris in the prednisolone arm. So initiate prednisolone along with ART in a patient who has drug sensitive TB and is responding to your current ATT, and the CD4 is less than 100. This is very, very important intervention to reduce the incidence of TB iris. The other issue, special populations, is the neural tube defects, which were previously being of major concern in reproductive age women with dolutegravir. But current data suggests that the risk of neural tube defects is as equal, very low, as with non-DTG conception. So in women of reproductive age group, you don't really need to worry about DTG, though you can have a discussion with the women of this possibility of NTDs if they conceive on dolutegravir. What about mother to child transmission of HIV regardless of pregnancy status? The same regimens that integrase inhibitor based regimen, like with dolutegravir, for example, is recommended in pregnancy for prevention of mother to child transmission of HIV. So this study here, the impact shows there is the best actual drug in terms of adverse event tolerability as well as neonatal survival was a TAF FTC DTG. So the preferred regimen for women with pregnancy to prevent mother to child transmission as well as for the mother's own health is TDF TAF FTC with DTG. For HIV HBV co-infection, a recent trial demonstrated a combination of TAF FTC with the integrase inhibitor bictegravir versus TDF was superior. The TAF regimen was superior to TDF in terms of reducing HBV DNA, the normalization of ALT, E antigen and S antigen seroconversion. So perhaps you may need to, in the HIV HBV context, look at using TAF, pairing the integrase inhibitor with TAF rather than TDF. The other issue is the use of antiretroviral therapy for prevention. This is talked as treatment as prevention, and we have important studies. The HPTN 052 study demonstrated a reduction in the risk of transmission, linked HIV transmission among serodiscordant couples when the viral load was undetectable after initiating ART. And this is same with the homosexual couples as well. So the concept of U is equal to U is important. So U is equal to U means if the viral load is undetectable, you are untransmissible. And this has to be promoted to our patients because our patients, remember, we used to counsel them to practice safer sex. But if they are undetectable, they would no longer need to use condoms or other preventive methods from the HIV perspective. So this is very important to propagate in our clinic population. Finally, let me end by giving you a brief update on PrEP and PEP. So we know now that in the IPREX study, TDF-FTC was associated with lower risk of incident HIV infection as compared to placebo in the MSM population. And in the MSM and transgender population, TAF-FTC was also associated and actually was better than TDF-FTC in reducing HIV infection. So PrEP is in our own clinical practice can be offered to individuals who report with high-risk behaviors to us, particularly in STI clinics, and also HIV discordant couples in which the partner has recently started ART, and it would take about 8 to 12 weeks for the viral load to go undetectable. So the serodiscordant partner can take PrEP during this brief period till the viral load goes undetectable. Which PrEP is used? TDF-FTC can be used for all groups. TAF-FTC currently is only recommended for the MSM population because it has not been studied still in heterosexual population. Once somebody is on PrEP, which is supposed to be taken daily, you need to monitor renal if the patient is on TDF and also look for other STIs and do HIV screening every 3 months. Important is also to counsel patients to tell them that PrEP should not lead to risk disinhibition. That means they should not get another STIs, because this happens often that patient take PrEP and then they would not really be worried about using protection condoms, and this can lead to acquisition of other STIs. So it's important to tell them that. There has been a big movement. It's not available in India, but using injectable PrEP, long acting, and this is a study in women which shows injectable cabotegravir, which is an integrase inhibitor, given every 8 weeks, was able to dramatically reduce the risk of acquisition of HIV. So this is the future, and currently WHO in its latest update on HIV prevention has recommended injectable cabotegravir, but this is something which has access issues, and I'm not sure when we will be able to offer it to our patients in our own country. Finally, post-exposure prophylaxis. Interestingly, these is the activities for which post-exposure prophylaxis may be recommended. So as you see here, if the source patient is undetectable, that means the patient is on treatment and antiretroviral treatment, and the viral load is undetectable, recent viral load, then post-exposure prophylaxis is not recommended for any activity. So this is very, very important to remember, to know the source as soon as exposure happens, to know the source, patients and viral load status. As far as occupational post-exposure prophylaxis is concerned, if there is sharps injury and mucosal splash, and if the source patient is having a detectable viral load, then it is recommended. For sexual activities, receptive insertive anal sex, receptive vaginal sex, maybe insertive vaginal sex may be recommended. But even in this context, if the source patient is undetectable, then you don't need to use post-exposure. Remember, we talked about U is equal to U when we talked about treatment as prevention. In other sexual activities, there is no recommendation for use of PrEP. So what PEP we use is basically you start them as soon as possible within 72 hours. Currently, the popular regimen is an integrase based regimen, either raltegravir, dolutegravir, or even bictegravir. Latest data we have available now. We don't know whether we can use TAF, but perhaps it should be okay to use a TAF based combination. So a 3-drug combination of backbone of TAF or TDF based nucleoside with an integrase inhibitor is a preferred ARV regimen for PEP. How long we need to take it? For 28 days, but after ruling out baseline HIV infection and HPV. If the source patient was on antiviral treatment and failing the antiviral drugs, the viral load is detectable, then we need to tailor it based on the resistance, possibility of resistance to the ARVs. So this is something which is not of a major concern now, because majority of our patients are really undetectable with antiviral treatment. So in summary, ART has converted, as we all know, HIV into a chronic manageable illness. Our patients are aging well. We have now cohort with us with the median follow-up of at least 20 years. Metabolic issues due to aging and contemporary ART needs to be screened for and efficiently managed. I briefly mentioned to you about weight gain, as well as issues relating to diabetes and other metabolic complications. The most important aspect of ART is its prevention benefit, and proactive communication of U is equal to U needs to be done to our patients so that they can basically stop really being concerned about transmitting HIV to their partners. And finally, PrEP uptake, in spite of the evidence with the oral PrEP, of course, we don't have injectable. We don't see that as part of our national program, or even in our own clinics. We need to really counsel our high-risk individuals and proactively suggest them to take pre-exposure prophylaxis. So I'll stop there, and if there are any questions, I'll be happy to take.
If there are any questions for Sanjay Pujari? Yeah. Yes, sir. So my question is, so healthcare personnel exposed to HIV, use equal to use not applicable. What is the reason for that? And other question is regarding like TAP and using TAP with rifampicin. I think there is very limited data that it may be okay. And then also, I think one more study where they looked at, it was an observational study, I think in Africa, where they looked at dolutegravir 50 OD versus 100 OD in patients with rifampicin, and they did not find much of a difference in the proportion were biologically suppressed. I think so.
Did you get that?
Yeah, so I got the last two questions. The question on TAF with rifampicin. So in that context, currently the recommendation of the package insert of Gilead says that you can't use together. Of course, there are some PK studies which show that even if the plasma levels of tenofovir is lower, the triphosphate level intracellularly in the context of TAF with rifampicin is actually higher than TDF alone. But we don't have clinical data as such, and that is why we are still not recommending TAF to be used with the rifampicin. The second aspect is DTG OD with rifampicin. Yes, there is an observational study. The inspiring study, which also used DTG BID versus efavirenz, was a phase 2 study. There is some PK data from Thailand, which was presented recently at the Montreal conference, which looks at DTG OD with rifampicin versus DTG OD without rifampicin. There was a dramatic decline in DTG levels in the plasma, although all the patients had undetectable viral load after the end of the study period. But we need phase 3 studies before we start recommending DTG OD with food along with rifampicin. That is the reason why we continue to recommend DTG BID until we await further data. I didn't get your first question.
No, sir. U is equal to U. We don't like healthcare worker exposed to HIV and source is biologically suppressed. We still give the healthcare worker
no need to give if the source patient is undetectable, no need for the healthcare worker to take PEP.
No, not required. Okay, I thought okay, sure.
The guidelines that I showed you, the chart is from the latest British HIV Association guidelines, published last month in HIV medicine.
Oh, thank you.
Any other questions, please? One more question.
In case of CNS toxoplasmosis, also we need to be aware of iris and initiation of ART along with cryptococcal and DBM.
In toxoplasmosis, I think the data is very clear about your timing of ART in the ACTG, I think 5164 or some, the study which looked at it within 15 days was okay in terms of preventing progression of HIV disease. The risk of toxoplasma iris is much lower than TB iris, but if it occurs, you may see increase in the lesion size, which happens with the increased perilesional edema. One important thing about toxoplasmosis is a recent review in the systematic review in the Open Forum Infectious Disease published, I think, about 2 months ago, demonstrated that just treating cerebral toxoplasmosis with TMP-SMX, standard cotrimoxazole, 1 double strength tablet twice a day, is equivalent to giving a combination of pyrimethamine, sulfadiazine, and folinic acid, because we know pyrimethamine is not widely available routinely in the community, as well as the pill burden of sulfadiazine is high. So now we have been treating whatever cerebral toxo we see with TMP-SMX, and rather than pyrimethamine, sulfadiazine, and folinic acid.